So everyone, welcome to the second part of our education series, Harnessing Informatics Education, which is what this whole series is about. The first one was sort of an introduction and overview of the landscape and the environment. And this one, we're really going to get into sort of the nitty gritty and the experiences of folks who have already done this. People who have done informatics education in multiple countries and in different groups, community health workers, nurses, allied health professionals, and physicians. So we're going to hear from them. So I'm really excited to sort of understand their experiences. We here at CHOP are the Global Health Informatics Program. I'm one of the co-chairs. If you saw the first one, that was led by my colleague Sansini, who got to join us today, which is great. She really organized all of this. And deserves the credit for it. I'm just stepping in to moderate because she's been out recently. This is our QR code. If you want to sort of connect with us, we're happy to talk, chat. If you have questions or anything about what we do or want to tell us about what you do, please reach out. We already sort of started to talk about this. We want to share, we want to build a community. There's lots of people doing amazing work out there. And we want to learn from them, and we want to sort of share it with everyone else so that we can all sort of grow and get better together. We want to identify key health informatics domains, outline health informatics educational needs of clinicians and non-clinicians, and understand how important the role of education is and how you approach it. And so that's really sort of the goal of these steps. We said we already did part one. This is our part two. We are hoping to have a part 3 at some point. We haven't scheduled that though, but keep your eyes and ears open. We will let you know. There are CME credits available if you're at CHOP and Penn for this. Unfortunately, we're not able to offer it if you're outside of our sort of immediate domain. These are our incredible speakers, which I will introduce a little bit more in depth before each of their presentations. And so we're going to start with Joya Nunez, specialist in pediatrics and health informatics. Her goal is to leverage technology to enhance healthcare experiences in order to improve people's interactions with health information systems. Dr. Nunez currently serves as a digital health researcher at Adhera Health, where she works on improving user experience when interacting with digital health platforms. With a focus on family units, her team supports individuals with chronic illnesses and healthcare teams towards shared decision-making. Responsibilities span from a clinical perspective and research to product design and development. Additionally, she is a member of lots of organizations and active in AMIA, the American Academy of Pediatrics, the Information and Communication Technologies Subcommittee of the Argentine Society of Pediatrics, and HL7 Argentina. She's also part of the scientific committee for the SAPTICS conference and the Argentine Congress of Health Informatics. And so with that, Joya, I'll hand it over to you.
Okay, thank you. And thank you very much for the presentation and the invitation also to take part in this panel of discussion. So I've been asked to talk a little bit about the general aspects of education in health informatics, mostly in low and middle income countries. I'm from Argentina, which is in Latin America, and also to talk about my own experience. So I'll try to go from the general aspects to my personal experience. So in Argentina, some of the key challenges that we deal when we're talking about health informatics is the level of informatization and digitalizations that we have in the healthcare space. We're still dealing with a lot of paper-based registry that involve also manual data capturing. Also, we have some gaps between the professional and the IT personal training regarding the health informatics area specifically. And there are some socioeconomic disparities that affect access to healthcare. As I imagine, it's a usual problem, not specific to Argentina particularly. But also, there's a lot of opportunities that are arising and that lead to improvement. And I see that a lot of that has to do with some collaboration between governments, different organizations, technology providers, stakeholders, startups, small businesses, as well as healthcare organizations per se. And that leads to a unified goal and participation in a bigger, broader manner. So if you want to go to the next slide. When we talk about the specific needs for health informatics, since this is a discipline that combines the healthcare field as well as the informatic or IT sphere, I thought that there were different goals and different mindsets towards the approach of each one. So for the frontline healthcare professionals, the main goal is to be able to use and apply practical applications to their daily basis, as well as see direct patient care benefits. This might include from basic IT skills like computer, mobile, electronic health records, or being able to use telemedicine platforms or provide electronic prescriptions, as well as identify and be able to include the clinical decision support system, be aware of some data and security constraints. This is a key aspect that I think that education has a lot of opportunity, because there are a lot of things that we might not be aware when we are doing that might have an impact on data privacy, and we're not really conscious about it. So education has a lot of opportunity there. And then there's mobile health applications for patients. I think this is a great opportunity for education of the patients, the families, the caregivers, and to empower them and this shared decision making towards healthcare. And for all of this to work, I think it's very important that the tools, the technological tools, are included in their workflow. They need to be a tool for them, and not a new job per se, a new constraint, because that way it will create a lot of resistance and it will not be helpful. So this last aspect, I think it's key. And then we have the IT professionals that I think their goal, if you want to go to the next slide, I think their goal is more related with technical and strategic understanding of health informatics, and focusing their knowledge in design, implementation, and maintenance of these healthcare systems working. So here we have a lot of also different aspects, like, well, the system design and implementation per se, also being aware of the interoperability standards to be able to exchange information without losing any data, some data management and analytics tool to be able to measure and quantify everything that we work on. Well, as well as the data and security, there's cybersecurity and regulatory compliance that needs to be addressed, and it's very important. There are many different legislations, and they can vary across different countries, or even within the same area. There might be different laws or regulations, and all have to be addressed. And also there are some project management and user experience skills that need to be applied, and always being in the lookout for emerging technologies and trends like AI, blockchain, Internet of Things, etc. So now, talking about my personal experience, I'm originally from Argentina, and all my education I received in Argentina as well. So I couldn't find this graphic in English, I'm sorry, but I will explain it. And basically, at the bottom, we have the high school degree. And after that, there's a 1 year max period of leveling from different schools and stuff. And from that, we can go to pre-grad and grad. It's not necessary to go through a pre-grad step. We can go to grad stage from high school as well. And one thing that I find particularly interesting about this is that most degrees that up to the grad level might be obtained for free. There's free education in Argentina. And then after grad school, there's the postgrad or specialization, and most of those degrees are private. And that's where health informatics goes. There's no health informatics grad school yet, or not now. And in the postgrad education, we have different levels of specialty or specialization. That depends on the amount of hours, of the practices, of the professionalism, different aspects that lead to different type of degree. So the first one is specialization, then there's the master's degree, and then the PhD. But also there are some other types of degrees like diploma or courses or different types of things. So if you want to go to the next slide, I feel like particularly in Argentina and also in Latin America, after the pandemic, it's become very apparent the need of obtaining health informatics skills, and the need for expanding on this area became really huge. So there's a lot of different type of courses and degrees and diplomas that started appearing in the region in Latin America. So I included some just as an example. There's links there if you want to have more information. And as you can see, most of them are virtual, which implies that there's also some tech IT skill set needed for completing this. So in this specific area, I took a health informatics master's degree, which I did it at the Italian hospital in Buenos Aires, which is the first one in the region that had a program and a master's degree validated. And for me, this is very theoretically framework. It serves as a concept and theoretical knowledge. But then there's a lot of classmates and colleagues that tell me that it's very nice and very useful, but then when they need to implement or apply all this knowledge, they lack some practical experience. So that's when it became apparent the need for a practical exercise type of education. If you want to go to the next slide. In Argentina, there are actually two health informatics residencies. One is from the government, and the other is also from the Italian hospital in Buenos Aires, which is the one that is available since the year 2000. So it has 24 years of age, and it can be in dual modality, both as a basic specialization or also as a fellowship after residency is already been completed. So this is the list of contents, very generic, very generically speaking. We have different areas of application, but this residency is project oriented, which means that depending on which projects you get assigned, you get a different profile from your colleagues. So this is very interesting, and it can be seen both as an advantage or a disadvantage, depending on your own profile and your expectations. But it also gives you a broad spectrum of what to expect and how to apply all these different knowledgement and in all these different areas. So there's a lot of jobs and skill sets that can come from this mindset. So after I did all these steps, I first did a pediatric residency. I then did the master's degree while I did the health informatics residency. And in that way, I was able to apply all the theoretical knowledge into the practical field. And I was going from one and the other. So it was very helpful for me. Now, this is a question that I get asked a lot, because once that you completed all this, how can you take it into the real world? So I wanted to share some of my current experience now, which is at this company called Atira Health. If you want to go to the next slide. So my job position right now is called Digital Health Researcher, and it's a combination between research but also product development, and it involves any clinical aspect of the workflow. I'm usually involved as well. So what we do at the company, we are leveraging health informatics to enhance healthcare delivery. And I was lucky that we combine health informatics with pediatric health, digital health, which is my main specialty.
Sorry,
so
1 minute.
Sorry, I'm almost done. So we're achieving efficient, effective, and pediatric patient-centered care with a focus on family units. We are delivering our products for the patient, but the caregiver as well. And we have some unique pediatric considerations that make this population specifically different than the rest. We all know that pediatric patients have different physiological and anatomical values and aspects from adults, and that we can see them at different stages that are very dynamic and that grow across populations. And we have a huge impact from social determinants of health that are now always captured electronically. So there's a lot of data from pediatric patients that might be lost at the electronic record. So, and also there are a lot of considerations, legal and ethical, that vary with maturity and age, and we have to be aware of that. So we apply some different strategies to address these specific considerations. If you want to go to the next and last slide, which are these strategies for mitigating these challenges. We use AI responsible frameworks. This means that we research the frameworks before we apply them, and we also develop our own frameworks that we then validate them. We involve stakeholders at very early stages. We apply ethics, inclusiveness, and context adaptations for patients from different populations with diverse backgrounds, with different needs. And we provide tools both for families and providers. So we take into account their own different needs, and we design and develop for each profile specifically, always keeping in mind the health outcome benefit that might come from this. And we validate this through research and both the product as the health outcome. So I think that's my time. Thank you very much. This is my contact information, and I'm more than happy to stay for the questions later.
Wonderful. Thank you so much. I'll mention, if people do have questions, feel free to put them, again, type them in the chat, and we will come back at the end, and hopefully the speakers can address them. We're going to run straightforward to Charlie next, Global Director of the Digital Health and Data Analytics for the Elizabeth Glaser Pediatric AIDS Foundation. He has over 17 years of experience working in strategic and operational planning, organizational structures, scalable networking, information systems, machine learning, collaborative tools, system design, and ICT development. A little bit of everything, or a lot of everything. He has a PhD in computer science, applied technology, majoring in computer vision AI for medical auto disease diagnostics, master's in information and communication engineering, and majored in computer vision AI with a bachelor's in IT. He's currently working with Elizabeth Glaser Pediatric AIDS Foundation as a global director of digital health and data analytics with multiple country teams in over 16 countries across the globe. He has served as the PEPFAR CDC-funded Health Information Systems Project Director for EGPAF Malawi, managing national electronic medical record systems for the entire country at over 800 sites. He's previously worked with Range of Motion Robotics, a Silicon Valley digital health company with branches in Shenzhen, China, and Cape Town, South Africa, working as CTO, leading a multinational team of engineers in developing rehab, mobile, and web apps for patients who underwent joint surgery. And so with that, I will hand it over to Charlie.
Thank you. Next slide, please. I think I will mainly share the experience which EGPAF have been doing in multiple countries in implementing, digital health systems. And then through the implementation of those, there are different knowledge gaps or educational gaps which we face across multiple countries. I'll just pick a use case for Malawi. But by the introduction, I work for Elizabeth Gray's Pediatric AIDS Foundation. In short, it's called EGPAF. It's a global leader in the fight against or to end HIV and AIDS, with 35 years of HIV programming implementation experience. We operate around 16 countries, mainly sub-Saharan African countries. And then within our operations, we have a lot of digital health, innovations across. Next slide, for time's sake. So I'll just tell you a couple of approach which we take when we are implementing, digital health solutions within the countries. From the previous slide, as you might seen, we have a presence in Malawi, DRC, Cameroon, where we demonstrated digital health solutions, and specifically in Malawi, where we are a national partner, where we have implemented nationwide systems or ecosystems. And within those implementations, there have been some trainings or some knowledge or capacity building which we have been providing to the Minister of Health or MOH. Next slide. So we are driven by three principles. Principle number one, we focus at point of service, where a clinician is interfacing with a patient. And then the approach, we actually train the clinicians to change the way they see digitization in, having systems or EHRs which are designed to assist clinician decision support, rather than having systems which are designed to collect data. So it's a big paradigm shift. We are also thinking of the systems which are based on clinical guidelines and algorithms, which are called smart guidelines, and moving away from systems which just mimic, a register or paper forms or MasterCards for collecting data. And this specifically moving away from record management systems into patient or clinical management system. When we usually introduce these kind of systems to clinicians, it's a big paradigm shift. And we systematically create training curriculums to onboard them into this kind of thinking, which is effective. than changing a clinician to be a data entry clerk. Next slide. To emphasize on principle one, where if you look to your, is it left? You see a classical, data entry form, systems-based, most of them, they're called EMRs, EHRs, which are a form where usually clinicians or data entry clerks, they enter data at point of service or maybe retrospective after the end of day. We move away from that into an interactive decision support or clinical guidance pathway to your right, where it's intuitive and it's able to support, the clinician as a tool, maybe providing flags. As you can see here, it's just a vitals toolbox. Instead of just having a field to enter your weight, you have this intuitive decision support form, which actually also alerts you if you're moving away from the guidelines. Next slide. There is also a new approach which we usually do. Over time, we have noted that for a clinician to have, more like a co-pilot of a tool so that they can use intuitively to support the client, there is this point of sale approach. We call it a Starbug theory, where we have point of sale devices at point of service, which are intuitive enough with touch screens, big icons, and then does not distract the clinicians from actually attending the patient, rather than supports them as an additive tool. So we also train and provide a lot of education in queue management using the point of sale devices, mimicking from an example of your Starbucks, your Walmart approach, where a salesperson manages a lot of queue, but ensure that their standard, and also everyone is saved with the right standard of care, I should say. Next slide. The principle number 2, apart from the point of service, we look at the entire hospital, and then saying that having an ecosystem of, let's say, microservices which talks to each other, having a hospital-wide digitization, meaning that the focus is the patient, not maybe a specific disease or a specific area, where when a patient goes into a hospital facility, at every service point, it's fully digitized, and then data can be exchanged from one service to the other, whether they're going to the lab, whether they're going to maternity, or whether they're going to oncology, and so on and so forth, having this ecosystem. And then when we are introducing this in low-income countries, it's a big shift. And then we usually bring in packages to let the clinicians, easily onboard into this new way of providing care. I'll not go into details with time. Maybe next slide. Next slide. Okay. The third principle which we apply when we are digitizing, no, previous slide, sorry, on principle 3. At national level, where we adopt international standards like health information exchange, which is specifically, we use OpenHIE in having interoperable systems across a country, which governs the way digital health supposed to be used within the health sector. So I know most of the folks here, you might recognize this diagram. We adopt this at national level to provide a single source of truth, where multiple systems and multiple facilities, they're able to feed information at a central level to feed the health shared record and then inform, the nation or the ministry on trends, case-based surveillance, and so on and so forth. So there is a new set of knowledge which we impact the Ministry of Health, the governments, in adopting, this kind of architecture at a national level. And then at every point, there are different skill sets which we actually train the different individuals from governance to high level technical knowledge. Next slide. Next slide. Yeah, and I just wanted to give you a use case for Malawi specifically, because we have successfully implemented a nationwide, digitization through the PEPFAR funding with CDC, where the focus has been, HIV and AIDS, but PEPFAR in Malawi has allowed us to use these principles to say, yes, we have that what we call ART client, but does not only interface at one area within the hospital. They interface with all other areas within the health systems. So in Malawi, as of now, there are about 271 sites which are fully point of care clinical management systems, which is hospital wide. And these are big hospitals like central hospitals, district hospitals, big community hospitals, referral hospitals, which have got high volumes of clients going through those hospitals. But apart from that, we also have other rural clinics which we have digitized with a retrospective system called eMastercard, about 500 something hospitals, which covers together like 100% coverage for all hospitals in Malawi which are offering HIV and AIDS services. The over 70% of the clients, they reside in the 271 sites, which are fully automated. But apart from that, we managed to create or automate, bring in lab systems across all labs in Malawi, including molecular labs, district labs, these are referral labs, and then also other bigger facility labs, which samples are referred to those labs. So there's 100% automation in Malawi for all the lab systems. And then apart from that, we actually digitized what we call civil registration and vital statistics systems. This is the electronic birth certificate generation and electronic death certificate generation, where every Malawian who is born and is given a birth certificate comes from this system. And also people who have died and death certificate is generated, they are passing through the system nationwide. And then all these systems actually push data into what we call data lake, which is the health shared record at national level within the ministry over a network. And then apart from for these systems to run, we actually support the activities in blue there, where we provide support for power, network, system administration, security, help desk, asset management, and user capacity. And that's the trainings which we provide nationwide in all these over 700 something facilities, which there is a lot of knowledge which we have impacted, and also we have pivoted the Ministry of Health in Malawi. Go next slide.
Sorry, and 1 minute.
Okay, I'll rush through. I'll just share. There are four points which we have learned when we are implementing this systems and the knowledge gaps we have identified. The first one is end user knowledge, where we systematically build curriculums and then also on-site training and also help desk support. And then when we are introducing the system for the first time, we actually build in a hand-holding, support for over a month just to manage the change. Next slide. The second gap which we saw is actually the Ministry of Health of Government technical support team, which are either at site or at regional or at district level, where we offer detailed training in infrastructure troubleshooting, and these might be electricians, this might be technicians, and also we call HMIS officers, which we handhold to manage, power network and also the system itself. And then we actually sponsor some, especially electrician, to go through proper solar power systems certifications across, and also conduct joint knowledge transfer and so on and so forth. Next slide. The third one, my slide. Yeah, the third one is at national level within the OpenHIE architecture, which is the most challenging one, where it involves advanced system governance and also national architecture. Like specifically in Malawi, we started the identification within the ministry qualified cadres to actually manage big data systems, data centers, which we're trying to set up. It's a challenge, but we end up identifying some, specifically one, and then take them through in setting up, this high-end Hyperflex infrastructure, and also getting the team certified with Cisco and ISO 27001, which is for security, and then training on how to use advanced networks, and also enterprise ecosystem like LDAP or domain and so on and so forth, or monitoring also infrastructure at a national level. Next slide. The second from the last is also the gap of understanding big data and data use. This is where we provide package, because we have within the data lake, we have artifacts which produce analytics. And then we train packages to interact with analytics at facility level, at national level, and so on, but also train, the HMIS or informatics within the ministry how to use BI tools like Power BI, Tableau, and others, and then basic training on predictive AI to start making predictions out of the data coming out. Next slide. The last experience or gap is actual the system maintenance, because these are as you might know by now that this is a unique system. It's not a common data entry system, but these are patient management systems which we deploy across. It's not one system, but it's an ecosystem. So to maintain, and these are mostly open source systems, to maintain these, we actually train, or identify software developers within the Ministry of Governments, and then implement together so that we transfer knowledge, the technologies like FIRE and other standards as well. This is a big challenge where the governments and the ministries do not have this kind of cadre, and most of them are either partners and so on and so forth. Lastly, on recommendation, and I close, is on the next slide. within the national systems, we've noted that we need deliberate programs to train skill cadre at all levels within the HIE architecture. We need government should also invest on high skilled engineers to manage national HIE. Clinicians themselves, they need to have digital health tools training embedded within their diploma and degree courses. And also data collects should be repurposed into M&E and also data use or informatics teams, because we are kind of retiring data collects into this new cadre where clinicians will have tools to implement, to use the systems, and those systems will collect data automatically. Thank you. There's a link for our work, and then you can reach out, and I'll be available for questions. Over.
Thank you so much. Unsurprisingly, we're going to run over time. We normally do. We do try to stay around afterwards if you can, but I will also ask the presenters to check the chat because I think people have asked a couple questions. So feel free to go ahead and answer them in the chat if you'd like. And then again, we can discuss them at the end. And everyone, we do put these up online on the CHOP YouTube channel. That's why we're recording it. So you should have availability to it, even the stuff after if you're not able to stay for the whole thing. Next we get to invite two presenters, which we love. So Jacob is an experienced health informatics specialist with over 10 years of experience in software development, monitoring and evaluation, and health data management. He's made significant contributions towards improving health outcomes in Zambia through his work on various e-health systems and data collection tools to support data management in the HIV program in Zambia. He currently serves as the Strategic Information Manager at CIDRZ. In this role, he leads a technical team that supports the development and deployment of electronic health record systems. He's also led the development of innovations like an Android application to support increased uptake of voluntary medical male circumcision, a DHIS2 platform used by provincial health offices to report on progress towards 95-95-95 targets, and a mobile phone-based survey tool to capture the quality of service provision from the patient's perspective to improve their experience in HIV clinics. Most recently, he's led the development of pioneering health informatics competency framework in Zambia, which resulted in the development of undergraduate and postgraduate health informatics curricula at the University of Zambia and Lusaka College of Nursery and Midwifery. He has also led the development of health data governance documentation for the Ministry of Health. He holds a master's in information systems management from the University of Greenwich and a bachelor's degree in computer science from the University of Zambia. And then also we have Yasa, a seasoned health informatics professional with a Bachelor of Computer Science degree and a master's degree in epidemiology and biostatistics in progress. She has over 11 years of experience in PEPFAR programs with a focus on developing health informatics competencies. These include training healthcare workers on collecting and reporting ART data using electronic health records. She excels at stakeholder engagement, collaborating effectively with the Ministry of Health and partners to execute various digital health initiatives. Her leadership in this area has been exemplified by her role leading activities such as on-the-job training and quality assurance, quality control activities during large-scale EHR deployments across 4 provinces. She's also contributed to an HIV recent infection surveillance program dashboard by mapping testing facilities and ensuring data accuracy through alignment with various sources. Additionally, she led data quality assurance and control efforts via audits, enabling program performance tracking, root cause analysis, and performance improvement recommendations. She's currently spearheading a needs assessment for nurses to identify knowledge gaps and inform curricula development in nursing informatics. She's also leading an ongoing ICT organizational assessment to evaluate the Ministry of Health's ICT team's skill set for implementing the digital health strategy. And with that, I turn it over to you.
All right, thank you so much. I'm mostly going to speak about the work we have been doing in the development of a health informatics curriculum for 2 education institutions. Next slide, please. But before I do that, I will speak about the background of our organization, CIDERS, which stands for the Center for Infectious Disease Research in Zambia. So CIDERS is an independent, local, non-governmental health organization that has been an active partner for the government of the Republic of Zambia through the Ministry of Health and other ministries since 2001. CIDERS experts utilize innovative and collaborative approaches to develop research, health services, and training initiatives with measurable results. The CIDERS vision is a Zambia and a region in which all people have access to quality healthcare. And our mission is to improve access to quality healthcare in Zambia. Next slide. So I'm not going to talk about the specific activity around curriculum development. The CIDERS-led health informatics curriculum development work has been made possible by the implementation of the Data Modernization Initiative in Zambia, which is supported by CDC funding and collaborating partners. This initiative aims to modernize the healthcare data systems aligned with the Zambia Digital Health Strategy, which was launched in 2022. A key focus is on enhancing digital health skills among Ministry of Health staff through targeted training in data analytics, electronic health records, and telemedicine. So our journey started from the development of a health informatics competency framework. This was followed by a needs assessment, which my colleague will speak about, and an ICT organizational assessment. We conducted several workshops and also conducted an exchange visit with the University of KwaZulu-Natal to benchmark our curriculum against their medical informatics program. Next slide. Next slide, please. Next slide again. So I already spoke about our roadmap, which was presented in the previous slides. What we're showing now is a slide on the 7 domains of expertise in which health informaticians require cognitive competence aligned to 2 of the 6 revised Bloom's taxonomy of educational objective levels, which are understanding and applying. So for the applying domain level, we have information technology, information science, leadership and management, communication and collaboration, public health, and research. For the understanding domain level, we have clinical health. So this is a summary of what is documented in our health informatics competency framework, and it forms the foundation for all the training programs that we supported developing at the 2 institutions that we'll speak about. But it also can be used by any other training institutions in Zambia because it was signed off by the Higher Education Authority. So at this point in our presentation, I'll hand over to Yasa, who will walk us through summary results from the surveys we conducted amongst nurses as well as ICT professionals at health facilities. So the needs assessment was conducted across 10 provinces in Zambia. Next slide, please. The needs assessment was conducted across all 10 provinces in Zambia, administered to frontline healthcare workers at 202 facilities, while the IT assessment was conducted also across the country amongst Ministry of Health IT professionals. At this point, I'll stop and allow Yasa to speak. Next slide, please.
Thank you, Jacob. I will proceed and talk about the results of the needs assessment. The objectives of our needs assessment were as follows: gather demographic information, determine the knowledge and experience of healthcare workers in computer use, assess the availability of resources, determine the education and training needs to inform the development of health informatics curriculum, and lastly, to assess the workforce, the workforce's knowledge and use of health data for evidence-based decision-making. And the next slide will look at participants' characteristics. Next slide, please. From our assessments, we had a total of 1,410 nurses who responded to the needs assessment. The participants included 231 males and 1,179 female. The majority of participants, 81%, hold nursing diplomas, and most participants have a minimum of 5 years professional work experience. In the next slide, we're going to present the findings regarding knowledge levels and training gaps in the use of healthcare software and computer applications. Next slide, please. The graphs show that among nurses, the greatest familiarity with healthcare software was observed in SmartCare, a national electronic health system used in public facilities, with 69%. In contrast, all other software systems assessed exhibited familiarity levels below 20%, highlighting a significant training gap in that field. Regarding computer application programs and tools, over 60% of participants are knowledgeable. Next slide. During our assessment, we found that laptops are available to 57% of staff in the facilities that were assessed, followed by desktop computers at 36%. Tablets and smartphones are accessible to 19% and 18% respectively, with 25% lacking access to any form of these devices. Internet connectivity is present in 73% of the assessed health facilities, emphasizing a considerable digital inclusion. Yet 27% still lack this essential service of internet connectivity. Next slide. In terms of familiarity of health informatics concepts, only 15% demonstrated a strong level of familiarity in health informatics. Additionally, it was found that only 13% of the participants have received training in health informatics, which highlights a significant training gap in this area. When asked about their willingness to learn more about health informatics, 99% of participants expressed eagerness as illustrated in the chart above. Next slide. The findings from the assessment reviewed low engagement in consulting evidence-based guidelines and research, with only 25% of participants consistently doing so. Additionally, a mere 4% of participants demonstrated knowledge of the policies governing ICTs in Zambia, highlighting a significant gap in awareness and adherence to these guidelines. Next slide. Finally, after the results of the NSA's needs assessment, the curriculum development was done. Based on the health informatics competence framework that my colleague spoke about and the results of the needs assessments, the University of Zambia and Lusaka College of Nursing developed undergraduate, postgraduate, and short courses training programs in health informatics. The Bachelor of Science program is targeted at school leavers. The postgraduate diploma is targeted at undergraduates, non-medical, and medical professionals in pre and post service. And the Master of Science is targeted at undergraduates, non-medical, and medical professionals in both pre and post service. With the Lusaka College of Nursing, we introduced a curriculum for short courses that were developed targeted at nurses in both pre and post-service. Next slide. In addition to some of the works we have done regarding health informatics, an ICT organizational assessment was done. The main objective of this assessment was to assess the level of proficiency of ICT skills among Ministry of Health staff for the successful implementation of digital health in Zambia. The assessment will focus on the following thematic areas. Next slide. The thematic areas that were included in this assessment were as follows: leadership and governance, infrastructure, software testing, maintenance, development and design, legislation, policy and compliance, database administration, cybersecurity and safety, software development, data science, and lastly, system administration. Next slide. A total of 101 ICT staff from the Ministry of Health Zambia participated in the assessments, comprising 79 males and 22 females. The majority of participants, accounting for 51%, hold undergraduate degrees, while those with advanced degrees such as masters, constitute 6%. In contrast to the nurses' needs assessment, which included more females than males, the ICT assessment reviews a predominance of males in the field of ICT. Next slide. The results concerning legislation, policy, and guidelines indicate that a minimum of 50% of the participants are knowledgeable about ICT policies, showing a satisfactory level of awareness in this area. Next slide. For each of the thematic areas under the ICT assessment, we will present the overall performance. We noticed that for database administration and software design, at least 40% of the participants that responded to these sections got everything right. The highest gaps we saw were in software maintenance and data science, followed by software testing and software development. Next slide. Challenges and lessons learned throughout our curriculum development. I will start with the challenges. One of the challenges we faced is the resistance to change, to the introduction of health informatics as a discipline from a key stakeholder. And additionally, our funding for this initiative ends in September this year, which would have loved extended so that we see the full implementation of these programs in these learning institutions. Some of the lessons learned during the curriculum development were practical application to emphasize hands-on experience to bridge theory and real-world scenarios, interdisciplinary approach through integrating healthcare, technology, and education for a holistic curriculum. Continuous stakeholder engagement by involving healthcare professionals, educators, and industry to ensure relevance. Next slide. We would like to acknowledge the input of our partners, PATH, the Ministry of Health Zambia, the US Center for Disease Control, CDC, and the institutions such as UNZA and the Lusaka College of Nursing. We also thank the Children's Hospital of Philadelphia for this opportunity to present our works on this platform. Thank you very much.
Great. Thank you, everyone. We almost made it by 12. I know a number of people have probably jumped off by now, but if you haven't, and if the presenters can stick around, we're welcome to continue to discuss. Thank you, everyone, for joining, and thanks to the presenters, before we get into that, for the great presentations. I'm sorry I have to cut you short. You each could give an hour easily on your own, and it would be fascinating for the entire hour. So it sometimes feels like a shame that we want to try to cram it in so much, but we really want everyone to sort of see and get a glimpse of all the great work that everyone's doing. So thank you so much. If anyone has a question, please feel free to do the raise the hand in Teams. Otherwise, I'll go back through and chat and kind of see, because I know there were a couple that I saw. Raphael, go ahead.
Okay, can you hear me? Can you hear me? And my mic is my mic working? Can you hear me?
It's a little garbled.
Sorry.
So in the chat, you mentioned, are the tools open source? The ones that you've been discussing. And is it possible to collaborate via GitHub? Sorry, so the question again is, we've discussed a number of sort of software tools and implementations that are out there. And so it seems they're wondering, are these open source tools? Are these things that anyone can use? And if so, are they still being worked on and developed? Are they things people can collaborate on via a collaboration tool like GitHub?
Great. Can I take that one?
Yep, anyone.
Yes. Yeah. I think Raphael, the tools are open source. I think most of them, I mean, some of them are like public open source. Some of them are open source, but maybe tailor-made to a specific need. But most of them are open source that teams can collaborate via GitHub. I think we can collaborate more. I mean, we can link more because like for us, ECPAF is a big suite of tools, different tools talking to each other at a facility. So depending on the tools of interest, we can collaborate here.
Thank you.
Right, I'll respond in addition to what Charlie has said. In our context, we have a combination of open source and non-open source tools. Obviously, DHIS2 is the most common one that we have. But in terms of EHRs, for several years now, we've had SmartCare, which is, say, it's open source, but not necessarily available to the public. So there isn't that possibility for collaboration outside of the partners that are supporting the project. Over.
Thank you. Anyone else? Farai, go ahead.
Yeah, thanks for the presentation. So just a quick question to Yasa. So she cited some numbers on the availability of hardware and connectivity. I found it quite interesting that the percentage of people who had tablets was about 20%, which is very low. Smartphones also just about 18%, but the internet connectivity was very high at about 73%. In what context is this, and what would you attribute the low availability of smartphone devices for the study? Thanks.
So when it comes to the
Yeah, so you're still muted. Sorry.
sorry, when it comes to the availability of resources,
Sorry, I think you're muted again. I'm not sure what's. Sorry, Yasa, I think you're muted again. Maybe their speaker's off too.
okay, is this any better?
Yes, that's better.
I was saying when it comes to the availability of resources currently as a country, the Ministry of Health depends on donor-funded activities and implementing partners such as IHM, CIDAS to support the deployment of these digital tools to the various facilities. And our current setup is we have 10 provinces and a lot of these facilities in these 10 provinces. So you find that the equipment is not adequate to cater for all facilities. So not all facilities will have all this hardware equipment readily available because it's totally dependent on donor funding. Unless Jacob would like to add to that. Thank you.
Nothing to add, thanks.
Great. I think I saw Abdul with a question.
Hi, good afternoon. This is Aaliyah. This question is for Charlie. So my question is around really changing that paradigm, I think that you mentioned. And to me, that's just kind of like a culture shift. So I'm wondering what kind of things were kind of done to get everyone on board with these new changes. Thanks.
Thank you for that question. I think there are a couple of things we have experimented. The good thing about this paradigm shift is more when the clinicians, when you putting these systems to a clinician, it aligns to their core work, which is providing care. So most of them, when they learn at school, they learn guidelines, they learn processes, or when they are maybe treating a patient, there are systematic questions they ask to a patient in probing something. What we have done is get those guidelines, get those into interactive question support and embed them within these patient management system. So it's more related to what they do rather than what indicator they would have to get from that interface. So what we have done is create a tailor-made curriculum in we actually localize the curriculum where we look at the guidelines for a specific service point. It might be ANC, it might be TB, it might be also ART, where we actually relate whatever we are demonstrating within the patient management system to their actual clinical guidelines, to say normally this is what you do. And then after you have maybe done this, then you record in your register. Then we tend that to say, you can use this tool to support you doing this without you literally recording into the register or having, entering some data somewhere. So what we do, first of all, we bring, the facilitator together when it's new, do that in intense orientation to the paradigm shift. And then we consequently go on onboarding or hand-holding the team when the patient is coming through, making them sure the ease of use of that tool until it's become their second nature, and then we leave them to see the benefits of the tool. So it has been an experience, because one thing as ECPAF, what we have noted is that there wasn't any difference when we started the other implementation of EMR, the HRs. They're all paper forms, digitizations, collection of indicators, and more on the M&E and statistics part rather than clinician workflow automation. So it has been a learning process where we have learned and perfect and then create content for the clinicians up to we have a fully fledged curriculum for almost every service point, from the lab, OPD, ANC, maternity, ART, and so on and so forth at a service point. So I hope I've answered your question.
Yes, thank you so much.
Right. I think it's really interesting from everyone that, again, it's so clinician focused, which again, selfishly, I appreciate. Because I think we didn't do that well at all in the US. We really didn't. We sort of thought about clinicians as an afterthought. And so then when we go to treat patients and have to use these tools and they're so bad. And so I think it's really interesting and great that so much of the focus seems to be on integration with sort of workflows that are already in place and making sure that the education is around the clinicians and the tools work for the clinicians. And so I loved seeing that as a focus. Mahudo, I think.
Yeah, thank you very much. Yes, thank you very much for all the presentator. And my question goes to the Zambian team, in which for who I would like to ask, you are requesting the health informatician to have some skill or to have some expertise in the different domain, and those are quite heavy, or let's say deep domain, from informatic technology, from information science, leadership management, clinical public health research, clinical health. So are you expecting one person to have all those expertise, or it's a kind of teamwork where you develop, you look for a specific people having say each one of those expertise to make them work together to be able to develop whatever product you are working on?
I think I'll take
Is it
that one.
Thank you.
So the competency framework really is designed as a guide for different levels to develop different levels of training programs. So it can be used to develop training programs for undergraduates, postgraduates, as well as any other short courses that are identified by a training institution or professional organization. Like in our context, we have a National Council for Nurses. We do not expect the health informatician to be an expert in each of those domains. We expect them to have enough information about each of those domains to be able to operate at their chosen field or their area of interest, right? So we are going to have some informaticians who will lean more towards information science, other informaticians who will lean more towards data science, but we don't expect everyone to be an expert. Even before these programs, we started working on development of these programs. In our current setup, what we have is that there are different specializations at different levels for those who work, for those IT professionals, healthcare professionals who work in either at a health facility or even at national level at Ministry of Health. Not all of them are complete experts in the complete set of the competency frameworks. Over.
Thank you.
And I think that actually also leads into a question that you asked in the chat that I'd like to go back and address. Are the courses we spoke about in the trainings, have these been authorized, validated by in-country authorities? Are they recognized as sort of official certificates and degrees by the labor market and other people hiring?
So in our the current status is that these courses have been approved at the institutional level. The next step is approval by the Higher Education Authority, which will happen in the coming months. Once that is done, the actual enrollment into these training programs will commence. So for the last year and a half or so, we've been supporting the development of the curriculum for these programs, as well as validating the curriculum. The final step that remains is sign off by the Higher Education Authority in Zambia.
Let's see. I know we're running long, but I think there were a couple other questions. I think most of them have been answered. Oh,
I wanted just to make the link with what we had from Joya from Argentina, with those list of training data online and data also validated by the local authority. So anyone can apply and then go through and get certificate. And then if you get a certificate, then you are useful to the market, if I understand very well.
Yeah, what I meant is the courses that I showed on that list. They have different levels of degree. There's just a diploma that can be from 1 to 6 months. Then there's some short courses that can be taken in weeks, and then there are some more extensive programs like diplomas or a master's degree. Master's degree usually are 2 years long and require a final like thesis work to be done and obtain the degree. But then there's also the diploma, and those are usually 1 year long, and they're usually more focused on one specific area of health informatics. For instance, telemedicine or AI or different areas of the broad spectrum. And then there are some that are very specific to different countries or regions, not very general. For instance, there's one in Buenos Aires that's just for Buenos Aires, and to know and understand how the health informatics systems is the status at the moment. So there are different degrees with different validated by their governments, but with different weight on the market according to their demand and length.
Yeah, thank you very much.
Wonderful. All right. Well, any other questions? I love it that we have this interest. We still have a lot of people on the call, even though we're way over time. So I think that's great. I think it shows the interest, the quality of the presentations, you know, how invested everyone is in, and they appreciate this education. So I think we can go ahead and wrap it up there. If there's nothing else, speakers, once again, thank you so much. Thank you all for staying on, presenting all of your, you know, invaluable knowledge and experiences. Thanks everyone again for participating, for the questions. We love this sort of interaction. We love seeing the great work that everyone else is doing. So yeah, please let us know if there's anything else. Please reach out to us if there's questions, comments, any other sort of interactions. We love it. So again, thanks everyone for your continued commitment to this wonderful work. And have a good week.
Thank you.